The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good day to everyone. I appreciate your attendance at today's installment of my podcast, which revolves around understanding temporomandibular joint disorder. I'm Tony Urbanek, and I am pleased to be with you today to talk further on the current state of affairs and understanding regarding temporomandibular joint issues and problems. As I promised in previous installments, I'm going to try to make these a little more concise and topic focused, and try not to roam too much on the topic at hand. There'll be a lot of circling back to what I understand and what I have to teach and provide as far as examples. But today, I'm just going to call it, the current state of affairs and understanding regarding this problem. My history on this is really irrelevant because of my background, training, experience in both education, science, research, medicine, dentistry. I was able to connect many dots that were there present and are still there, but others have pretty much developed their understanding about it based only on what their experience and training and education has been. Let me just talk about one issue that occurred to me, one example of addressing this, and that is in March of 2019, March specifically 28th and 29th, I attended the consensus study regarding temporomandibular joint disorders held in Washington, D.C. At the National Academies of Sciences, Engineering, and Medicine. This is actually the book that was made regarding that consensus study and everything about it. I actually attended this and did a five-minute presentation on what my experience and findings were regarding inflammation and the direct correlation between inflammation of the temporomandibular joint and all the symptoms, and a very brief explanation of my findings in my own 3,000 patients here in Middle Tennessee. I've reviewed this, haven't read every word, but I've reviewed this report on that 2 days, and it goes into thoroughly about the current state of understanding of temporomandibular joint issues in all aspects. It covers the definitions and scope of TMD, the individual and societal burden of TMDs, the state of science on TMDs, caring for individuals with TMD, improving TMD healthcare, practice, education, access, coverage, improving patient, family, and public education awareness, and next steps and recommendations. Those were the topics. Nowhere in this book, either in summary or in specific, does it talk about inflammation within the temporomandibular joint directly causing all the symptoms associated with TMD. And my 5-minute presentation to that group specifically covered that statement, my experience, and what I believe is the direct cause. So it's not meant to be critical, it is what it is. And we can go over certain parts of this, and probably in the future we will. We'll pick out a couple things in here that I think are very relevant. There's some extremely good science noted in here. But again, and it states in here, basically in the vernacular, if all you have is a hammer, everything looks like a nail. And it's stated in here in so many words that that's one of the biggest problems we have here regarding temporomandibular joint disorders. So we'll cover this at future times in little detail. I don't want to be too pedantic, and I don't want to be too clever, and I'm not trying to cover information that is too esoteric and complicated, because that isn't how I deal with patients. That isn't how I deal in science in my career. So the first thing I just want to clarify again is that what I discovered in a very intuitive way, heuristic way, intuitive way, at the direction of my patients, is that if you take away, decrease the inflammation of the temporomandibular joint, the symptoms automatically go away. And you don't have to deal with the secondary symptoms directly, because the central nervous system takes care of that. And in previous installment, I explained what I discovered, and I'll review again very briefly, and that is when there's inflammation within the joint, and this occurs in any joint in the body, the hip, the knee, the elbow, the autonomic nervous system sends a signal to the central nervous system and says, hey, this joint is inflamed. The central nervous system processes it, and this is where it gets a little dicey and definitely has room for understanding. And that is what happens in the central nervous system for the signal to come back down through the autonomic system and tells the muscles to tighten up. But it's well known. Orthopedic surgeons know about it with tennis elbow. Tennis elbow, central nervous system says tighten up, and the muscles that support and move the elbow tighten up, and it creates pain and other symptoms, but primarily pain associated with those muscles are attached to the bone, and the nociceptors are in the periosteum next to the bone. And when the muscles tighten up and pull on the bone and the periosteum, it hurts. Ouch. That same system, autonomic system, works with this joint. And when that signal comes back to tighten up the muscles, sometimes this muscle, sometimes that muscle, they don't do symmetrical signals, and patients will complain of different symptoms associated with those muscles becoming tight. And the pain is directed right where the muscles attach to the bone, and patients will say, right there, doc, and right there, doc. And you'll have the muscles of mastication start to hurt. When it goes on long enough, signals come down. I told you, don't move the jaw. Now I want you to hold the whole head still, and the symptoms will cascade into the neck, and the patients will complain of, and they'll point exactly to where the insertions of the muscles are, the sternocleidomastoid, the trapezius. And when it goes on further, the signal comes down to hold the whole shoulder girdle tight. When that happens, patients will complain of shoulder and arm pain. And when the muscles on the side of the neck, the scalene muscles and the strap muscles the signal will get tight, they'll squeeze down on the brachial plexus, and patients will complain of arm, hand, finger tingling and numbness. Okay, we've covered that before, but just for review, it is so simple. What I don't understand is no one's looking at this. And all right, so couple things. I've personally financed an independent study through Middle Tennessee State University, which will be coming out shortly. I just saw the first material on that study. It's very validating, by the way, with what I found, and confirms what I know. Independent study done by Middle Tennessee State University, and we'll be talking about that in the future also. But today I wanted to kind of go into how I came up with this, and it wasn't in the usual way. There are two ways to reason through a problem. And as I said before in a previous installment, if you cannot find an answer to a problem, and I don't care what area of life it is, if you can't find an answer, you're either looking in the wrong place or you're asking the wrong people. Because I truly believe that if there is a problem, there is always an answer. Maybe difficult, maybe obtuse, maybe hard to find, but there's always an answer to a problem. Two ways to reason through a problem. There's inductive reasoning and deductive reasoning. Most science, and they're both scientific methods, and we all know the scientific method, and the scientific method comes into play in both inductive and deductive reasoning. So don't confuse what I'm talking about here. I'm talking about reasoning, not the scientific method. I'm not going to give you a review of the scientific method. You all learned it in high school. But I want to talk a little bit about the difference in the way you reason through a scientific problem. And that is, there's deductive reasoning, and that is how almost all reasoning in the sciences is done nowadays. There are many well-known scientists that didn't use deductive reasoning in the past. And I can go through a whole list of that. Einstein was a great example. He did not use deductive reasoning. He used more intuition and more inductive reasoning. But the difference between not to leave you hanging, and inductive reasoning is that you look at something that you intuitively may have either evidence or intuition that may be effective, and you heuristically try it out. And if it works, it works. And if it doesn't work, it doesn't work. And if it works, you probably actually don't know how it works. And deductive reasoning is just the opposite. Deductive reasoning is taking all of the facts available to you in that area of science or study, basically all the facts in the library. Here's my library. Of course, nowadays that's passé, and nobody pretty much likes books anymore, unfortunately for them. But in a library on a topic, you can find a bazillion facts, and those facts are often confusing, and but that is how most science is done, is to take all of the facts and to try to pick out from all of those thousands, hundred thousands, millions of facts, things that will agree and coalesce to explain what your thesis is. If your thesis is, let's just say your thesis, and let's keep it close. If your thesis is the position of the temporomandibular joint disc is either exclusively important or primarily important to temporomandibular joint problems. So you go into anatomy, physiology, neurosciences, histology, and you start picking out facts associated with the disc and the position of the disc, etc., and the relationship of the position of the disc to the different degrees and types of temporomandibular joint symptoms. You start picking out all the facts available to prove your point. And then if you develop enough facts that kind of coalesce together that make the case and it sounds reasonable, because you're reasoning now, then you publish a paper and you make the case for your thesis. that is the usual way of doing just about all of the science nowadays. Nothing wrong with it. It's just complicated. And the real problem with it is, what do you do when you find a fact that doesn't match what the other facts tell you? And so you'll run across something that is the antithesis of proving your point, and it doesn't match, it doesn't help. What do you do about all those facts? So, because we're talking about the conundrum of TMD, and this is a conundrum, and this is one of the reasons it's a conundrum, is that all of the reasoning that has gone in almost exclusively to trying to figure out temporomandibular joint problem has been done through deductive reasoning. So as I talked about in the previous installment, when I got into this, my own investigation, very simple, but I decided I was going to take an independent look at it. But I knew that I needed to start out at the beginning. I needed to start out with the patients. I already been through the textbooks and et cetera, and listened to everyone else's point of view and applied just about all that and found out nothing worked. So I went back to the beginning. I went back to the patient and started interviewing patients and asked the key question. See, the right people. If you don't have the answer, you're either asking the wrong people, in other words, my colleagues, the textbooks, the different meetings, or you're asking the wrong question. And in my case, it was both. I was asking the wrong people and I was asking the wrong question. So the right person to ask is the patient who has the problem, and almost magically, so quickly, they gave me the key. They didn't give me the solution, but they gave me the key that opened the door. And that is, when they kept hearing, if I put my finger, my tongue, a pencil eraser, a piece of cloth between my front teeth and bite down, it feels better. Made a device that separated the back teeth, and the rest is history. That was the beginning of inductive reasoning, because after I determined that how effective it was after 30, 40, 50 tries with patients and got the same results, I was mystified, and I then had to figure out anatomically, histologically, neurologically, even using physics, because the jaw is nothing more than a lever arm. The jaw is a lever arm. It has a single attachment, bilateral attachment. So, but using inductive reasoning, found something that worked, and then had to figure out how it worked. And what I determined was all the information that was there that explained how it worked was obvious. It's already in the literature. Pretty much all you have to do is point to it and read it, and there it is. So I wanted to clarify, inductive reasoning and deductive reasoning, and how this all came to be, and how both reasoning types are valid, but there's not much inductive reasoning anymore in the sciences that I'm aware of. So once you understand the cause, inflammation, it's easy to understand what to do about it. And the answer to that is decrease the inflammation. If the inflammation is the cause, then if you can figure out a way to decrease the inflammation, that would be the wise thing to do. In this case, there are other reasons, other methods to decrease inflammation. As we know, nonsteroidal medication is an extreme good example, but they don't last long. They're not effective for very long. And I can go through the litany of other things that can be done, but what I found is that long-term unloading the joint will balance out whatever loading goes on if you do it correctly according to a protocol. And the protocol that I figured out and used, maybe other protocols, this one works fairly well, actually very well, is to unload the joint 24/7 for a while, i.e. 2 months, and then go to nighttime only. You have to start 24/7 to really unload the joint, because the patient, for whatever reason, and there are only 3 causes: bruxism, trauma, and functional malocclusion, but they're overloading the joint, breaking the joint down. Breaking the joint down causes inflammation. Inflammation causes the symptoms. So if you understand the cause, the actual cause, the problem is inflammation, then it's easy to understand what to do, figure out how to get rid of inflammation. And in this case, a device and a protocol, a tool and a protocol that unloads the joint long enough to counteract the constant or prior overloading the joint and breaking down of the joint, creating inflammation. Now, once I started seeing tens and then hundreds and now thousands of patients with this problem, I came across, all of the alternative treatments that are available. And those alternative treatments are discussed here well in this volume. One of the other comments that's made one way or another, but very clearly made, is in this volume, is that there is no consensus. We don't know what to do. We have recommendations of the direction to go. But honestly, I'm quite surprised, especially after I clearly at least suggested, clearly made in a 5-minute presentation, at least take a look at inflammation itself, rather than going off into, unproven directions. It's not in here at all. But other treatments are mentioned, and we'll just go over a few, and maybe we can pick some of these apart. Again, my intention is not to be critical. My intention is to be enlightening and to look at this problem, first of all, using reasoning. That's why I went over inductive, deductive reasoning and the scientific method. I'm a scientist, but I understand there's a couple ways to reason things out. The treatments that are, attempted, used, and that I find are not effective, because I see patients all the time that have done many of these, some of them, even almost all of them, at one time or another, and are still sitting in my office with symptoms. And they can include, occlusal changes, equilibration, Invisalign, orthodontics, multiple kinds of drugs, many of them harmful. Night guards, that's the common, as you know, the common use of a night guard is for the general dentist to give it to the patient and say, this is going to treat your temporomandibular joint problems. It definitely guards the teeth, but it's not going to unload the joint. The physical therapists are going heavily toward dry needling, which physiologically understands trying to relax the muscle, but you're talking about doing something to the endpoint, to the symptom itself, and only that symptom. It doesn't cover any of the other symptoms of headache or arm, hand, finger tingling and numbness, tinnitus, vertigo, which are very common symptoms. The patient, they don't even recognize that it's coming from the temporomandibular joint. Of course, Botox, that's the one that is increasingly being used to paralyze the facial or neck muscles, and only some of them. And I've already talked about previous installments. So I have patients who have spent thousands or hundreds of thousands of dollars, either they or their insurance company, on Botox. And again, they're sitting in the office. And when you go like this, it hurts and the joint's inflamed. And when you make the inflammation goes away, the symptoms go away and they don't need any more Botox. The chiropractors are doing their thing to decompress nerves and, manipulate muscles to the same effect. You're addressing the symptom, which is on down the line from the actual cause. Massage therapist, we already talked about physical therapists. So I think I've made my point for today. I hope I've made it clearly. I pray that I've made it clearly. And at the end of this, I'm going to add that 5-minute presentation that I did in Washington, D.C. At the time of this consensus meeting, which resulted in this volume, which explained in detail the current situation that the scientists and of all varieties feel the present situation with temporomandibular joint problems within the United States of America. That was at the National Academies of Science, Engineering, and Medicine, and I'll attach that at the end if you'd like to watch that 5-minute presentation. So for today, we'll wrap it up, and I appreciate your attention and look forward to speaking with you again at the next installment of TMD Demystified.
I come to you this afternoon after a long day, which is very enlightening, as a patient advocate, a researcher, and a provider. Thank you for allowing me the opportunity to address the committee. My purpose is to direct the committee to an area of investigation that I have found productive. My name is Anthony Urbanek. I received my dental degree and master's degree in anatomy and cell biology from Indiana University and my medical degree from Vanderbilt while working toward a PhD in anatomy cell biology. In 1976, I was awarded a 2-year fellowship from the NIDCR, then known as the NIDR, for my self-directed study to induce reproducible temporomandibular joint craniofacial anomalies in an animal model by way of laser-induced intrauterine fetal surgery. After completing this study in my internship and residency in oral and maxillofacial surgery at Vanderbilt, I have spent the last 40 years in private practice in Nashville, having performed over 2,000 surgical procedures on the temporomandibular joint, half as open procedures and half as arthroscopic procedures with varying degrees of success and failure. I believe I am well qualified to comment on the current research, treatment modalities, and provider training for the amelioration of the symptoms of TMD. 10 years ago, after applying all my surgical skills and knowledge to the conundrum of TMD, and because of the less than predictable results, I decided that I could not, in good conscience, recommend surgery as the solution for the enigma. I had a burgeoning practice of patients, mostly females, showing up at my door requesting help, but I would now have to turn them away. Because of my broad background in the sciences and independent research, I decided instead to create my own study and ignore the myriad of congresses, textbooks, lectures, articles, and recommendations of colleagues from the many disciplines involved with the TMJ. I decided to instead apply the guiding light of my career. If one cannot find a solution to a problem, he is either asking the wrong questions or asking the wrong people, or both. So began a study by collecting data from the actual source with a very simple process. I began sitting with my patients and asking them and encouraging them to tell me everything they could about their symptoms, their history, and their problem with TMD. Many of them, at least half of the cohort, which was 12 out of 24, many of them repeated a similar comment. If I place a pencil eraser, my tongue, my finger between my front teeth and gently bite down, it feels better. After hearing this multiple times, the light bulb ignited, and I thought, I wonder, What will happen if I make a device that fits between the front teeth and that it can be worn for 24/7? I constructed such a device and gave it to one of these patients who had symptoms for 20 years, asking her to keep it in her mouth 24/7, taking it out only to eat, and return in 3 weeks. 3 weeks later, much to my surprise, she said her symptoms were all gone. Then I applied this strategy to another patient and another and another. Not everyone had 100% of their symptoms subside after 3 weeks, but everyone had substantial improvement and continued to improve over time to the point of wearing the device limited to nighttime only. After treating 30 or 40 patients in this manner, I knew the anterior occlusion, disoccluding the posterior teeth, was effective, but I had no idea how it worked. None. What were the anatomic, physiologic, pathologic, neurologic mechanisms at play that allowed a simple device that only occluded the anterior teeth and disoccluded the posterior teeth to have such a profound effect on relieving the symptoms of TMD in patients who had suffered symptoms for 10, 20, or 30 years? The next step consisted of what Albert Einstein euphemistically called thought experiments. For sake of brevity, I only have 5 minutes. I will give you the factual findings in bullet form. 1, every TMJ patient I operated on had inflammation as the consistent common denominator in the first line of the pathology report of the mandatory tissue sample. In other words, the common denominator of all TMJ problems in my practice was inflammation. 2, 90% of the loads on the temporomandibular joint are from the posterior teeth. This fact has been validated by many, many dental studies. 3, and the centerpiece of my remarks and the understanding of the conundrum and the route to a most viable solution is this. Inflammation within the temporomandibular joint stimulates an autonomic response from the central nervous system to contract first the muscles of mastication, then the muscles of the neck, then the muscles of the shoulder girdle to hold the TMJ immobile in contradistinction to the constant mobility of the joint in normal function and bruxism. This mechanism, well known to our colleagues in the orthopedic literature, explains muscle trismus in tennis elbow, but is conspicuously absent from the dental literature relevant to trismus of the muscles of mastication in TMD. Conclusion. Unloading the temporomandibular joint in a defined manner to offset the continued and unavoidable loading of this joint will predictably alleviate inflammation within the joint and associated symptoms of TMD. Using this protocol, I have successfully treated over 2,000 patients in the past 6 years who continue to report amelioration of symptoms using the devices prescribed. Therefore, I respectfully recommend to this committee focus on evidence-based research and methods for unloading the temporomandibular joint while maintaining normal daily function as a superior way to treat symptoms of the TMD.